Welcome to the Hopkins Economics of Aging and Services Center monthly seminar. We're delighted today to have Karen Shen joining us to talk about her work. For those who don't yet know Karen, she joined us this past year in the Department of Health Policy and Management as an assistant professor. Her training is in economics. She's a health economist, and her research, including what she's talking about today, thinking about caregiving workforce and long-term quality of care for older adults. She thinks about questions also in mental health and substance abuse. And a lot of work is guided by the impact of state and federal policy. And she finished her PhD a couple of years ago at Harvard Business School, and we're delighted that she's a part of our community, and I'm going to turn the floor over to her. Welcome, Karen. Thanks for speaking with us today.
Great. Thanks, Dan. Thanks, Jennifer. Thanks, Nadia, for organizing. I'm excited to be here, and I thought I would kind of give, like, I don't know, a little bit of a mixed talk with some new work and also just some background on the topic of Medicaid policy variation in the delivery of long-term services and supports to older adults, which is something I'm really interested in, just getting my feet wet with. And, you know, I would love for this to be like a discussion. If anybody has ideas or thoughts or questions, please feel free to interrupt me. You know, I am happy to not hear myself talk for the whole time. So I think it'll be fun. So a little overview of what I am planning to do. I thought I would start by just presenting some kind of descriptive statistics about Medicaid LTSS spending across both time and place, and then give you guys a sense of what policy variation might be driving some of that spending variation that we're seeing. I will talk about some papers that I really like that have already come out about Medicaid state variation in LTSS spending. And then, you know, depending on how much time we have, I'll talk about kind of two newer projects that are just like getting off the ground. And, you know, very happy for feedback of any form on those, and then I'll wrap up. Great. A lot of these figures are screenshotted, so sorry that some of them are blurry, but I guess, you know, I don't think it necessarily needs that much motivation for this audience, but I think it is useful to just center ourselves around how big of a cost LTSS is to our healthcare system, and then, you know, to understand why we're talking about Medicaid, it really is because Medicaid is the largest payer for LTSS in our country. So this is a report from the Congressional Research Service that shows that we spend almost $500 billion on LTSS, long-term services and supports. That goes mainly towards older adults, but also serves people with intellectual and developmental disabilities and physical disabilities, some mental illnesses, etc. So that's capturing about 10% of total healthcare expenditures. So it's big. And importantly, I put a little exclamation point here. That's not even considering the cost of unpaid care. So for older adults, it's been well documented that families provide the vast majority of care, and, you know, when they're unpaid, which is almost always, that the value of that care is not getting figured into these spending numbers. Nonetheless, you know, we see Medicaid spending about 200 billion of that 500 billion. And so that is about a third of the total Medicaid budget that is going to long-term services and supports. And it's about 42% of total LTSS spending. How has that Medicaid spending kind of evolved over the past 40 years? So here I took kind of Medicaid spending per our 65 plus population to try and get like a little bit of a denominator for what the demand for these services might be. This is all in real dollars. The data starts in 1982. And basically you see between 1982 and 2000, there is almost a doubling, actually probably more than a doubling of real spending through Medicaid on long-term services and supports. During that time, it was mostly nursing home spending, but you see the growth of the blue portion, that's home and community-based care spending, really starting to grow in the like late 1990s. But you know, for the first 2 decades, it's really a story of like more and more investment. Starting in around 2000 and until now, spending through Medicaid per senior has been pretty stable. And what we have been seeing is actually kind of a reallocation of spending away from nursing homes and towards home and community-based care. And that is commonly called rebalancing by kind of the policymakers and advocacy organizations in this space. You know, I think one of the most striking facts to me that I find really interesting is that there is just absolutely huge variation across states in how Medicaid is investing in LTSS overall and how they are allocating that spending. And so here, you know, I've broken out that spending into the two main types, nursing home spending and home and community-based care spending, scaled it all by senior and plotted like the state maps of what that spending look like. And on the right, you know, many of you have probably seen the work of like the Dartmouth group in the Dartmouth Atlas, which is talking a lot about how much geographic variation in spending we see across places. So there are certain places that just spend a lot more on healthcare than other places. One of the common statistics that they calculate using that data is if you took the top 10% of hospital referral regions for them, and you took their average spending, and then you divided that by this average spending for the lowest spending areas, what would the ratio of those two spending numbers look like? So for acute Medicare reimbursement, the ratio that the Dartmouth Atlas has been exploring is about 1.3. So the highest hospital referral regions are spending, you know, 30% more than the lowest. If you start looking at Medicaid LTSS spending, and I did these across states, I did this yesterday, so, you know, I think they're right. You're getting a ratio more like of, you know, five times as much in the top states is being spent per older adult than in the lowest 5 states. And you see something similar for nursing home spending. And then when you turn to actually home and community-based care spending, the ratio goes to 12.5 times the amount that's being spent in low spending areas. So, you know, I think this variation kind of dwarfs what we were seeing in the Medicare population. So I think it, you know, this is something that feels very worth studying for me. Looking at the two maps on the left, I think another important point to raise is it's not always the case that, you know, the states that are spending the most on nursing home care are spending the least on home and community-based care, right? There are some states like New York, for example, that are spending a lot on both. And so there's really all of these different considerations when you're trying to like tell a story of what's happening in these states, where some states, you know, might be just enrolling more Medicaid enrollees overall in LTSS. Some states might be pushing the substitution of home care over nursing home care. And so there's like a lot to really dig into to get a good understanding of this variation. So this is just kind of driving that point home. Here I kind of just plotted nursing home spending per older adult against home and community-based care spending per older adult, and what you actually observe is a positive correlation, not a negative correlation, right? And you see New York and DC up in that top corner where they're just spending a lot. If I do per enrollee instead of per older adult, you see that correlation diminishing significantly. So there is something about enrollment and eligibility kind of driving, you know, one component of the variation across states. But I think like what this raises for me is, you know, there is not one best measure of state Medicaid generosity, and a lot of the ones that are commonly used in the literature, you know, might not necessarily capture what you want to capture for a given research question. So I think, you know, one lesson from this is that we should be very careful about when we're thinking about enrollment differences and when we're thinking about place of care differences, and you know, when we're thinking about rebalancing and when we're thinking about eligibility. And so these are some of the things that I'm like issues I'm trying to grapple with every day. So I guess my view of like this problem is that we are just now beginning to uncover kind of both the causes and the consequences of this, you know, huge variation in Medicaid LTSS spending. So I think, you know, none of these questions that I've listed here have been answered, you know, completely yet. So I'm curious what policies have actually been driving the shift to home and community-based care over time within Medicaid. What policies explain this variation across states? And then obviously, what are the downstream effects of this variation in spending on actual LTSS access, health outcomes, and outcomes for family members who are caring for these people? And then, you know, I think it's important to not just think about access, but also to think about quality. And I think, you know, the quality of what is being delivered and how it corresponds to spending is, you know, kind of a problem that has not even gotten close to being resolved yet. Great. So let me summarize a little bit about what I know about the policy background, and I'm not, you know, the premier expert in this, so I'm very happy to hear anybody else's views on it. But I kind of think about the sources of Medicaid LTSS policy variation as being, you know, variation in who Medicaid might serve, what it might provide, and how it might provide those services, right? So on the who side, there's all of this variation in Medicaid eligibility rules. You know, today I'm thinking mostly about older adults. So the only requirement, and this can even be fudged by states, is that Medicaid provide coverage for older adults who also receive SSI, which means that your income is about 74, I think it's 74% of the federal poverty line. Many states extend that income threshold up to 100% FPL. And then there are also all of these programs that can allow states to extend that income threshold higher for certain groups, like people who might need institutional care. So it can go up to 150%, 300% FPL. So that's one source of variation. In general, you also have to both meet an asset threshold, and that asset threshold is often just $2,000 for an individual or $3,000 for a couple. But again, a big source of state variation can be what assets do they allow you to exclude. So they always allow you to exclude your primary residence, but certain states can raise those thresholds and also increase the exclusions that might shift who's eligible for Medicaid over time. A big path through which older adults who need long-term care receive Medicaid eligibility is through what is known as medically needy programs, which essentially allow you to count any medical expenses you have against your income. So if you've subtracted those expenses from your income and now you're below 100% FPL, you can qualify for Medicaid. Not all states have these programs. Some states are more strict about it. You know, like this is a common source of variation that's been studied in the past, but I think still deserves further study since we are kind of seeing these big enrollment differences. And then finally, pretty much for all of the home and community-based services that I'm primarily concerned about, states do like contract out agencies to do functional assessments that can then determine whether or not you're eligible for care. And the way those assessments are done might differ, and the rules about how, like, you know, having 1 or 2 ADL difficulties might translate into whether or not you're eligible for care might differ. So there's lots of variation here in how you might, whether or not you might be eligible for Medicaid, depending on what state you live in, depending on what rules they have. In terms of what Medicaid covers, it is required to cover nursing home care, but all other home and community-based care is actually optional. So every state gets to elect whether or not it is covering any of the services that I listed and more, right? So there could be a huge amount of variation there. And then finally, and this is the how and the what are connected. There are different program authorities that Medicaid uses to cover LTSS. So one is called the optional state plan benefit, which essentially makes HCBS similar to like any other benefit in any other health plan. So it's essentially like an entitlement-like benefit where if you meet the eligibility criteria, you're supposed to be provided the service. The first optional state plan HCBS benefit was for personal care, so an aide to come into your home. That was implemented in the 1970s. And then recent reforms have extended that authority to other benefits, pretty much anything I listed in the second column. So now any state can choose to use the state plan authority to cover HCBS. So Maryland does this now through the Community First Choice program, which was passed in the ACA. And so basically that program was kind of, they offered states a 6% increase in their federal matching percentage if they used state plan authorities to cover HCBS rather than waivers, which I'll talk about next. And I think about 9 states took that up. The second major authority under which you might get services are called 1915C waivers, which are home and community-based services waivers. And these kind of differ from a state plan benefit in that states are granted much more flexibility initially on what services were covered. Now that's kind of moot because of the 1915I and 1915K. But they're also granted flexibility in targeting specific services to specific populations and in being allowed to set enrollment or cost caps, which is not like an entitlement benefit, right? Which can create these kind of wait lists that sometimes appear in the news. Finally, there's been a recent growth of kind of managed LTSS. And so that's kind of similar to Medicare Advantage or Medicaid managed care, where rather than the state administering these services or contracting out these services, the state pays an insurance provider a capitated amount per patient, and then they, do all of the authorization of services and assessment of who gets services and potentially connects you to a care manager, et cetera. Just to kind of like summarize a little bit, I think this issue of like program authority is kind of the most complicated. And I just want to emphasize that LTSS spending across these kind of different program types varies significantly by the population that's being served. And so here I've kind of split out the LTSS spending by, into waivers, state plan services, and institutional care for both the kind of aged and physically disabled eligibility group. So that's where the older adults would mostly sit, and then the intellectually and developmentally disabled group, which is kind of a huge share of spending. And what you see is that like I think in kind of like, this is maybe like a little bit my soapbox, but I think because we talk a lot about 1915C waivers when we're talking about HCBS, partly because there's sometimes more data available on them, but also because they represent a huge share of overall spending. But a lot of that spending is going to this IDD population and not to older adults. And when you look at the older adults population, you actually see that these state plan funded services are more common. And so I think just—
Can I ask a question?
Yeah.
I should have helped set the ground rules at the beginning. I'll say, you're allowed to interrupt, I guess, as long as it's the host. Anyway, this is amazing because I have so many questions along the way, but I really like this figure, and it says 2016, like how much has it changed in the, like, if do we have any data on that? But if you had to guess, like, is it that dark blue bar is growing in relation to the orange one for age and physical? Like, is that the big, seems like that's what you're getting at, but did the data bear that out? Did it look different in 5 years earlier?
Yeah, great question. The data is broken is the answer. And actually, like, this is something I meant to bring up on this slide, which is that all of these numbers come from these like Mathematica-driven reports that look at expenditures. And actually, starting in 2017, Mathematica said we're not going to report these breakouts by population anymore because we're becoming less and less confident that we are measuring those breakouts correctly, partly because of like the growth of managed care, and partly just because sometimes the data isn't actually clear about what population is being served, particularly for the state plan services. So I think these are the best numbers we have, and I think they roughly represent what spending looks like for these two populations, but it's become more and more difficult to track changes over time as like different program authorities have entered and managed care has entered the space. And so they literally don't make these figures for 2021 anymore.
So this kind of follows the theme of your talk, is that there are tons of really, really pressing and interesting questions and not tons of answers, and it's complicated.
Right. Great summary. Yeah, thanks, Dan.
We could have done this in 5 minutes,
We still can, yeah.
No, please.
Okay. Okay, well, this is where I was going. Now you see. What are the challenges with studying this state Medicaid LTSS variation? This slide is going to have 3 parts, just so you know. First is that it's actually pretty difficult to know just, ones and zeros, like does a state cover X, does a state cover Y, and then trying to go back in time is even harder. I've like talked to some librarians about this. I've sent them in circles. It's tough. And one extra reason it's tough, besides just like you have to, I think, read like old Medicaid program documents to know, is there's so much variation. Like you saw that kind of like table that I put up of all the sources of variation, that it's actually hard to know which policies matter more than others. So it's hard to even know what to track and what to start digging in the stacks for. And related to this, the observed variation that we're seeing in spending is the product of so many interacting systems and policies. It's not the case that, you know, we saw New York and California spending a lot on HCBS, and you know, that spending was growing. It's not really the case that the California state legislature is coming out and making a statement that we're going to spend X billion next year on HCBS, you know, and then we're just studying the downstream effects of that variation. Because so many of these things are kind of like entitlement funded, you know, and they're eligibility funded, and it depends on how like the local agencies like implement these programs and assess people. The variation we're seeing is the product of all of that. And so, you know, it's hard to do kind of like traditional like difference in difference analysis on like one policy shock, because a lot of these programs kind of grow over time and evolve, and they're evolving kind of independent, I think, of like some big like, you know, congressional act happening that's saying like things are going to change. They're changing more on the ground, is my sense. Challenges part 2 is about data, and this is what I have to say about that. There's 2 main sources of kind of aggregate state level enrollment and expenditure data. There's the Kaiser Family Foundation does these program surveys of Medicaid administrators, and they ask Medicaid administrators for like total spending by authority, total enrollment, as well as like eligibility criteria and wait list numbers. And then there's actual program data from some CMS forum that Mathematica and Truven publish that looks at expenditures as well. So in that sense, it's like, it's not terrible. But I think as I've dug in, you know, I've just found over and over again that there are kind of significant measurement issues in these data. And, you know, Mathematica says it as well in that they, you know, have stopped publishing certain numbers because they're becoming less confident about them. It's kind of hard, maybe impossible, to allocate the spending correctly across the different, even just the different disability populations, which is already very coarse, right? Just saying like this went to somebody who is in the aged and physically disabled category versus the IDD category is already difficult. With the enrollment data, like many people might get services through multiple programs. And so the enrollment data that we have from the Kaiser Family Foundation doesn't allow us to identify like the number of unique users, which is probably a little bit more what you're interested in if you want to think about access. We definitely have no idea, you know, is the spending we're seeing like a lot of people getting a little or a few people getting a lot, right? So the distribution is unknown. And then is the spending variation we're seeing driven by prices, or is it driven by quantities? You know, we also don't necessarily know that from this aggregate data. And so here I would just say, like, I think there's a lot of room, and I'm willing to work with anybody who wants to work on this, to use more patient level surveys or claims data to try and actually measure, you know, just investment at the state level, what it means for a person living in a given state, you know, what that state's Medicaid policy actually looks like in terms of impacting their utilization. This is a quick aside on wait lists, because I do think that the wait list issue shows up a lot in the news. When you look at the Kaiser Family Foundation data, 73% of people who they count as on wait lists are people who are in the intellectually and developmentally disabled population. Among, you know, the population I'm talking about today, older adults and people with physical disabilities, only 15 states have a wait list. And if you like look at which states those are that are reporting a wait list. Like some of it doesn't pass the smell test in terms of being like, these are states that are heavily restricting access to HCBS. So California is on there, as well as New Mexico, Texas, and Connecticut, which all looked really good when we were looking at spending per older adult. So, I think wait lists tell us something, but they obviously don't tell us everything. And so I think it's important to think beyond wait lists, and when we're trying to think about which states are better serving our this population. Okay, so the attempts thus far to kind of categorize or describe this variation, I think the AARP scorecard is a very common one, which ranks states by, I think they have like maybe 40 or 50 measures. I only listed the ones that are kind of related to Medicaid here, but they also look at like the supply of nursing homes and assisted living, and I think they look at costs and stuff. But the Medicaid measures that they use are, what share of the low income self-care difficulty population is enrolled in Medicaid. They take the number of Medicaid LTSS users and they divide that by the total self-care difficulty population. So these are kind of their measures of access that they're putting in there. And then in terms of measures of choice of provider and setting domain, they essentially look at the rebalancing measures. So the share of Medicaid spending that goes towards HCBS and the share of users who use HCBS. I think my thought on these is like, I do think this is like they're doing really important thing, and that they're capturing a lot of variation across a lot of domains, and probably getting some sense of which states are doing well and which states are performing poorly. You can see the kind of ranking here, but pretty much all of these measures use kind of the data that we were just talking about, the aggregated data, to calculate these like numerators and denominators. And I think sometimes it can be a little bit difficult to make sense of like, well, what does this mean for an older adult with ADRD? Like what's the probability that what is their actual like ability to access a Medicaid service? So I think there's more room to do here. And then I just wanted to call out like some other work that is actually going through and, constructing new data about what policies are available. So this is Megan Skira. They went and looked at the 1915 C waivers and looked at, constructed a historical panel essentially of what services are being covered by each waiver over time. And so you see that pretty much everybody covers home-based services, and that ends up being one of the biggest sources of growth in the waiver spending between 2000 and 2017. And then, I just think this is like kind of amazing work that they've gone and done. So I just wanted to call it out. Okay, I will move on to a few papers that I think are interesting and exciting in exploring this variation. I think this will be relatively quick. So I think an early seminal paper in this space was looking at nursing home use by David Grabowski and John Gruber in 2007. And so what they did here was they collected data. They did a similar like policy data collection exercise where they collected data on whether or not states had spend down, like the ability to spend down your assets, what the income threshold was, the asset threshold, what your spouse's asset threshold was, the reimbursement rate, whether or not there was a certificate of need. And they looked in like kind of a difference in difference analysis on whether any of these policies affected nursing home use. And what they find is like a whole lot of zeros. So all of this Medicaid variation didn't really seem to shift people's use of nursing homes. Moving on to assisted living, Cheney and some other co-authors, I think, have done this really exciting work where they're able to use Medicare data to identify who lives in assisted living facilities. And they look by state at how many people who live in an assisted living facility are dual eligible, so are getting Medicaid, which likely means that Medicaid is paying for some portion of that stay. And what they find here is huge variation, right? You see like New York and Maine, above 40% of people in assisted living are dual eligible. And then you see, you know, like so many states down at the bottom where the number is closer to 5%, right? So assisted living is completely not being used by the Medicaid eligible population. So I think this is really cool. And I think they then put in a bunch of policy indicators, right? So what they look at is, do states have like a state plan benefit that covers assisted living or not? Do they have a waiver or not? And what they find is that like those policy variables do seem to be explaining a good amount of this variation. And so states that had, you know, I think in my memory, it's, you know, the state plan policy indicator for assisted living like shows up pretty strongly in terms of increasing the likelihood, the share of assisted living residents who are dual eligible. So that there's some sense that it seems like that variation is driving some of this variation that we see. In my own work that is not yet published, but will hopefully be published this year, I look at like a similar policy variation, and I'm using the health and retirement study to compare just two types of states that have, there's about 30 states that cover personal care through a state plan authority, and then everybody else only covers it through waivers. I take everybody in the health and retirement survey and I sort them by their income, and I put a red line to the left of which, you know, these are people for whom we expect them to be Medicaid eligible. And what you see is for that population, there's a big difference for you if you live in like a blue state versus an orange state, and whether or not this is for older adults who have a self-care difficulty. Do they also report what share of them report having a paid helper? And so you see, like, you know, my hypothesis is that the state plan authority seems to be driving this, you know, huge difference in whether or not older adults with self-care difficulties have paid home care. Jennifer, did you have a question?
Yeah, I just was curious, given your comments about the waivers, the wait lists, do you think that could be part of the explanation?
Yeah, well, so I guess, you know, that's kind of why I was like obsessing about the wait list. This is one of my dissertation papers, and so why I always like want to bring it up, which is like, you know, only 15 states say they have any wait lists. And that's including a lot of these state plan states. So there still is there still is something different. And I, you know, just like need to go out and talk to more like care managers in if something's covered through like a state plan and it's easy to get, or if you have to get in it at a waiver slot, there still seems to be some other mechanisms through which access is being limited that aren't just like you're strictly being placed on a wait list. So like it could be that just like it's not advertised in the right way to people, you know, like people think it's going to be really hard to get, so they don't even apply. I'm not really sure, but I don't think it's entirely driven by wait lists. Okay, so I think the potential takeaways from these three papers, I think there's two, and I'm not really sure which one is correct. One is that there's just less variation in Medicaid policy for nursing home care than HCBS, right? Because nursing home is a required benefit, and there's all these optional things that states can cover or not cover, and cover in different ways when we're talking about HCBS. The second possibility, I think this was kind of more proposed in the Grabowski and Gruber paper, is that demand for nursing home care is just not elastic. So once you're at the point where you need nursing home care, this is probably like you're the most sick, and like whether or not that care is going to be paid for by Medicaid just doesn't really kind of shift how many people are in nursing homes. On the other hand, we might think that demand for HCBS is a little bit more elastic because it can potentially be replaced by family caregivers, right? And so in the work that I did, I also found that in the states that had high rates of paid home care use, because they had a state plan benefit for paid home care, we also saw lower rates of kind of family caregiving, right? So those are my takeaways. I'm curious if anybody else has any others. Okay, I will go.
Does this mean the idea that, home HCBS would substitute for nursing home care? It's just like still like that Gruber study was old, but there's still no sense that evidence isn't showing up. I guess it makes me worried or wonder if, I think some of the rationale behind it was there'd be some substitution, but nothing you've shown has suggested that that's the case. And I guess, is that true? And then the follow-up is like, does it put some of the expansion at risk going forward if there's no kind of, financial payoff reducing nursing home stays?
Right. I mean, that's a tough question. I do think that in many cases, literature that has looked at expansions of HCBS has not found like enough of a nursing home care, and this includes my own work, enough of a reduction in nursing home use that it could like outweigh the additional costs of just like extra people taking up HCBS and, either just supplementing what they were getting from family caregivers or substituting some of family care away. So I do think that in thinking about HCBS going forward and advocating for its expansion, it's probably wise to focus on some of the other benefits besides just moving people out of nursing homes or keeping people out of nursing homes, which, might be a lot of this burden on families that we're currently placing as we're kind of shifting more and more care home.
Karen, I have a follow-up question. Do you know if there's been work done looking at the potential for HCBS to offset nursing home entry for people who don't have family caregivers or who have poor access to those types of informal supports? I wonder if the effects of HCBS might be more pronounced for that subpopulation.
Yeah. Yeah, so even in my own work, I wasn't super powered to study, but I did find that. And I think that is a general finding. If you're looking at people who don't have a lot of support, they probably are more on the margin of entering a nursing home versus not. I think the question becomes, do we want to specifically target that population because they're going to enter a nursing home, or, is it also just important to consider people who are overstretching their family supports as also eligible for services? Okay, great. So I know I have like 15 minutes left, so I will quickly just run through. I won't do all the slides on these, but kind of two like new projects that I'm thinking about, and just eager to get everybody's thoughts on. So one is like, to what extent can this variation in Medicaid LTSS spending explain growth in the home care workforce? So I'll show you this graph, which I really like, which is that we have just seen a massive explosion in the home care workforce over the past 20 years, especially. So here you are looking at people employed in home care industries, people employed in the nursing home industry, and people employed in other residential care. And you can see that just, you know, these are majority of these people are home care aides. So either home health aides or personal care aides, but you just see this massive explosion. Of course, the theme of this talk is that there's big state variation in that employment number. So here we're looking at home care employment per 1,000 people. And so you see this variation is again on the size order of, you know, 10 times in certain states, the employment rate compared to the lower employment states. And, you know, in emerging work, I'm kind of looking at over that 20-year period where we're seeing this big growth. How much did a state's HCBS investment change, right? So some barely changed at all. DC, I think, implemented a state plan personal care benefit in this time. And so its HCBS investment per older adult increased by $3,000 per older adult, so huge. And on the y-axis, I'm looking at how much did their home care industry grow. And so you can see this very strong relationship between the change in HCBS investment and the change in home care employment. And, you know, so this is just like another story that, like, I think this HCBS investment really matters. This variation really matters. And it's really, you know, explaining some of the employment, even the workforce trends that we're seeing, right? So I think one important implication of this work is, you know, if Medicaid policy is what is enabling the growth of this workforce, then it's also kind of responsible for regulating the quality of that work, and you know, it is also deciding through reimbursement rates what that job looks like for workers, right? So it was a big puzzle to me at first, like how we could have this massively growing workforce and everybody saying like there's not enough workers, but wages for this workforce are so low. Like that doesn't necessarily make economic sense until you realize that a lot of the reasons for the growth in the workforce might be Medicaid policy, and Medicaid policy just gets to decide the wage that workers get, right? So I think, you know, this work is just kind of emphasizing that Medicaid policy matters, and so we should be thinking about, you know, how it relates to the workforce as well. And then I presented this in a work in progress section for the HBHI a few weeks ago, so I'll spend even less time here, but this is joint with Rachel Wu, who's on this call, and one of our PhD students, but we're starting to look at the effects of the trend towards managed LTSS on older adults. And we're thinking about focusing specifically on older adults with ADRD. So in my view, it seems like MLTSS, managed LTSS, has been one of the last frontiers of managed care, following kind of Medicaid managed care, which usually used to exclude duals and LTSS services, and following Medicare Advantage. But in the last decade, there's been kind of a sharp growth in the adoption of MLTSS. And I would say that growth has kind of preceded a lot of evidence suggesting that MLTSS has like done what it's supposed to in reducing costs and improving quality. And so I'm not too sure why states have suddenly all jumped on board, but I think we're interested in thinking through the potential effects of MLTSS, whether it could be good or bad for patients. And I listed all these interesting hypotheses here. You know, and we're trying to kind of tease them apart using Medicare data. So I think one possibility is it can improve the coordination of care because, you know, these insurers provide like a case manager. But another possibility is it could be restricting access to some necessary services in the interest of cutting costs. It could also be restricting access to unnecessary services, right? So in the kind of more traditional managed care way. It could be directing patients to lower cost options, prioritizing those in a better way than the former fee for service system. It could be limiting, which providers patients are allowed to see and negotiating prices for those providers. That, I think, is a common source of savings in other managed care programs, but actually many states prohibit MLTSS from doing this. They require MLTSS to allow people to go to any nursing home, and they kind of set a floor on the rate that you can pay. So it's not actually clear that MLTSS can really do this, but I put it up there anyway. It's also possible that MLTSS does nothing but just upcodes everybody in order to get paid more. So I think there's a lot to think about.
Karen, I just wanted, so there's just a time check here. There's 10 minutes left, and there's a lot of experts on the in the room, and I'm wondering if we could go through the rest of the slides and maybe pause to see if it's okay with you, to see if people have comments or questions.
Yeah, that would be great. Yeah. I can wrap up in
a burning slide here.
a minute. No, so what we want to do is start using Medicare data, try to construct a cohort of people who we think are likely to be affected by MLTSS, like at the moment, like when might MLTSS matter to their care patterns, and then look for 5 states that have rolled out MLTSS recently in our study period, look at how MLTSS affects that care. So we haven't figured all of this out yet. So I think we're really hoping to hear from people on just like when you think MLTSS could plausibly matter, so that we can study it using Medicare data. So far we're looking at kind of nursing home residents and potentially avoidable hospitalizations. This is state adoption of MLTSS. This is the growth of MLTSS. We can come back to these. These are our 5 states where we're seeing things happen in our study period. And now I can wrap up. So my concluding thoughts are that Medicaid's role in LTSS provision has been growing and changing a lot over time. And because the federal government doesn't have strong kind of prescriptions for what states have to do, there's just been enormous variation generated across states, which potentially means there's huge inequalities across place, but also opportunities to learn. I think the big question for me is, do our current programs and policies, which were kind of mostly developed in a time where more people were using nursing homes and we didn't have as many people with dementia or other conditions that mean that they might need longer periods of care, can that system meet the current demand for kind of long periods of home and community-based care? So we're moving from a system where, Medicaid used to be the last payer for nursing home care, right? So like what happens at the very end, but now I think Medicaid might be the first or the only payer for home-based care. And so like are our rules, meeting that challenge? Particularly, as I've said many times during this talk, meeting the challenge of also supporting our family caregivers. And then finally, a big theme is we just need better data to understand who's able to access publicly financed LTSS and how well it's able to actually serve the needs of different populations, different diagnoses, et cetera. Thanks for having me. That's all I have.
You want to open it up?
Yes.
Cynthia.
Hi, Karen. That was a great talk. So informative. I learned a ton. I am curious, and I feel like these things are definitely intertwined, but I guess I'm just thinking of what we know about geographic variation in health status and disparities, whether anyone's sort of been able to overlay variation in both unmet need and overall need. Recognizing that I think that may vary across states as just one example. Along with obviously there being different policies and availability of the supports.
Yeah, great question. I did this just as a gut check, literally right before the talk to make sure I wasn't crazy. But here I've put a map of ADRD prevalence by state.
I'm not seeing it if you're showing us something.
Oh,
Sorry.
sorry.
It sounded like thought you were sharing your screen.
No, I was.
Sorry. about
No,
that.
you're fine. So like I think your point is totally well taken, and it's something I was thinking about a lot as I was putting together these slides, that like I'm using per older adult as my like denominator, but obviously that's not entirely correct, and we have to think about how the like chronic disease health status burden might vary across states. So I did do this, and I think I need to go back and see like if I can get these historical figures. These are from this is from the Alzheimer's Foundation. I mean, I know that there's also just been general like there's changes in diagnosis for Alzheimer's as well, but just thinking of ADRD as one instance in which like has been changing a lot over time and might be creating increased demand for care. This is the geographic variation there. And so you do see like states like New York like have a high prevalence of ADRD, and they also had high spending on HCBS. But I think like a great check is like Florida, which had very low HCBS spending and very high ADRD prevalence. So I think it's fair to say it's not entirely driven by health status, but
Right.
But yeah, I need.
Sorry, I didn't mean to cut you off. I thought.
No, is that like roughly what you're getting at?
I guess, right. So you could say, just theoretically speaking, right, New York is spending more because they are actually meeting need, but that Florida is spending less, perhaps because there's more and that there's unmet need, right? That there's people who are just going without services that they may actually, that in another state they would be getting. And so it's right, it's both variation in the health status and then which is, I think, to some degree, like it's probably aligned with actual need, right? But then need is broken down into need that's being met and unmet need. Do you know what I mean? Like,
Yeah,
so
absolutely. I think if you overlay like the spending graphs and these graphs, what will emerge is like some places which we could say like are probably suffering from unmet need. And then I think a lot of like the survey work, I know like the NHATS, like Cheney's other paper that's looking at like actual like times that somebody wasn't able to participate in a social activity or something like a more person-centered measure of kind of not having your needs met. I think that would also be important, and to the extent we could do that like with more people to really be able to measure geographic variation convincingly, I think would be really great.
Well, we have 1 minute left here. There's a couple messages in the chat, but I want to just thank Karen for an amazing talk, and it's such a fruitful area. And I imagine there are a few people here that will be contacting you to follow up. So thank you so much. And thank you all for joining us. It was terrific hour.